because then it's a little easier to find the midpoint of the sternum, and then you don't have to try again when you do the RAO and you can't see the sternum. It's more guesswork that way. So start with the lateral, less guesswork, more accurate when you go to do your RAO. So 72 for the lateral, and then you can, but you don't have to, bring it in to 40 for the RAO, right? So sometimes we like to use that purposeful magnification to help, right, some of the details of the sternum become visible, especially when we're also trying to blur out ribs and other fun things. So, like I said, in this case, it's easier to start at 72 with the lateral, and then, like I said, go into 40 when you go to do the RAO. So you'll have to change techniques when you go from the lateral to the RAO anyway. So for the lateral, right, the breathing instructions is take a deep breath in and hold it. We don't have them do any orthostatic breathing for the lateral, but we're going to make lots of, like I said, technique changes when we go to the RAO anyway. So changing from 72 to 40, take that into account when you're changing all your techniques anyway. And then ribs. So there are 6 areas, right, of injury, right? So right upper front, left upper front, right upper back, left upper back, and then right lower back and left lower back. Yes.
I would imagine, so if the pain is like very much so laterally, would I still be probably doing just counting it as like a posterior lower? Because,
yes.
okay.
So.
Good question.
I've had to get x-rays there before because it hurt there, so I was just curious how that would work.
Yeah.
Okay.
You treat it like a posterior.
Okay.
So there are 2 views that you do per injury. So like I said, there's 6 possible injury sites. You should have 12 pictures of the ribs. And then 2 more for the sternum. So by the end of today, there should be 14, right, images that go into your technique book.
Jesus.
So, your skills test, however, will only be one of the potential injury sites.
Okay.
There are 6 of you. There are 6 potential injury sites. Each one of you will have a unique injury site for your skills test next week. So, your skills test will only be 4 images, right? 2 for the sternum and then 2 for whichever rib injury I give you. Okay? But your technique book has to have all of the options.
So it'll be 14 views altogether, though, in the technique book.
Okay? Does this make sense to everybody? Okay. All right. So, let me... Okay, who wants to be the patient?
I was a patient last week.
Okay.
Just close my eyes.
Yeah, it worked pretty good.
It did.
Yeah, okay. I'll try that next time.
All right. So you're going to turn to your left first. Yeah, good. And go ahead and take a step back. A little more. All right. So you're going to find the jugular notch. You're going to find the xiphoid process, right? Right there. And then the midpoint between the 2.
If you can't feel the xiphoid on a bigger patient, you just then center how many inches from the jugular notch down?
I think, again, it's kind of your standard 3 to 4.
Okay.
But, again, each patient's going to be a little different, so make sure that whatever estimation you're using makes sense for your patient. Okay? All right. So, patient put their arms behind their back, so they really kind of puff out their chest a little bit. Yeah. Now, note that right now, I have it so that, right, the shadow kind of skims that center line. And that's okay, but I do want to make sure it's not rotated. Crazy. Because my breathing instructions are going to be what?
Hold on, inspiration.
Right, so take a deep breath in. You're going to notice, right, that shadow adjusted. So now I put, right, a little bit more into the actual center spot, okay? So, I can call it a summage. But yeah, plan for that, okay?
So it's by about 6 by 10 then?
I don't know how accurate that is, but yes. Okay, so that's my lateral. Now, to do the RAO, go ahead and face the board for me. Like I said, I don't necessarily have to change, right, my height, because that should be the same, right? But I'm going to go ahead and, right, center initially, and then I'm going to make my adjustment to my, right, 15 degrees, okay? And what that should do, right, is then shift the centering about that inch off of the spine, okay?
I'm just looking from this side here. So the lateral border should line up almost with the positioning of his EAM. Would that be also a good point to judge about that inch to help you?
Then it depends on your patient.
Okay.
Right, how thick their neck is, how thick, right? So I wouldn't necessarily use that as a true fast rule.
Okay.
But, okay. Again, remember that 15 degrees is very slit. Okay? So it's kind of hard to tell, but I'm thinking of this, right, as the shoulders, and so I'm only adjusting them a smidge. If you try to actually sink their shoulder all the way to the board, you will have rotated them too far.
Okay.
Okay? So the point is not to get their right side to touch. Okay, that's not really going to help you in this case. Especially women who have breasts, right? There's going to be some OID there. If you get women's shoulders to touch, you will have rotated them too far. Okay? So, again, posture is important. Make sure that that stays nice and straight. And like I said, that you don't over-rotate, because 15 and then 20, if they're really skinny, is still not very much rotation. Okay? So don't make the mistake of trying to, like I said, get their shoulder to touch, because that is far too much rotation. Okay? So, and on this one, breathing instructions are going to be
Orthostatic breathing.
orthostatic breathing, which is what? Short breaths, right? So hyperventilating a little bit, yep. So, and we increase our time, decrease our MA, so we still have a nice picture at the end. Okay. Markers for this one. Forgot that I didn't have one. But it does not really matter whether or not you use the right or the left. Just make that it is sure it's on the correct side of the body.
Now, would you want it inside the bucky or on the board?
Depends on your bucky and depends on your board.
Okay.
But on the board's probably safest. So, questions about sternum? So, lateral first, then the RAO. Okay. I did not choose to go into 40. I left it at 72, but you can come in if you would like. Same thing goes for the ribs. I think the ribs are kind of also that option. Some people do them at 40. Some people do them at 72, because we get used to doing chest things at 72. Again, as long as your technique matches. So, yes.
If you bring it into 40, your centering shouldn't change all that, right?
Correct.
You're just gonna play with collimation a little bit.
You will play with collimation a bit, yes. That's pretty much it. Yeah. Okay. So, remember that when we shift to the ribs, that we are going to do this, like I said, by injury.
Mm-hmm.
Okay? So I'm going to go ahead and do, since he's already facing the board, I'm going to do anterior injuries first, okay? Because those are going to be PA projections, right? And then an LAO or an RAO, but remember there's the opposites from the side that's injured. So I'm going to start with the right side, so shift a little bit to your left, nice and straight. Okay. So I'm going to come down my centering a little bit. I have to trick it, so I can change my. Okay, so remember to always have your patients salute. So go and bring your right arm up to your, yeah.
Hmm.
Okay. No rotation. Right, take a deep breath in and hold it. And this would be, right, my PA for a right upper anterior injury. Okay, go and relax.
So to get the scapula out.
That is
of
to
the way.
get the scapula out of the way of the ribs. Yes, it is. Right?
Can you do that again? I was curious to see if it would cut off the top there.
So,
Because it looked fine when his arm was down, but then he took that breath in, and I'm like rib 1 and 2's up so high. I just
it
couldn't.
might be close, but I don't know that I would cut it.
Okay.
But it's close. Yes. I don't know that I would go up too much higher, but I could maybe a smidge. So, now I'm going to do the, what's the other position for this injury?
The
Or-
LPO or LAO.
LAO. Yeah, again, arm up. So, I went 45 rotations, so this time I am going to sink that left shoulder to the board. And I'm going to make sure that I move the right side right into my crosshairs here. And I like to think of aiming kind of for that scapula-ish area. And then that should cover me. Okay. Again, take a deep breath in and hold it. And that's our other right position for this injury. Good, relax. Questions about that one? Okay, so doing the other side, you're gonna shift to your right. Let's stay straight first. Back this way a little. Left arm up to your forehead.
It's not uncommon for some places to want a lateral rib too.
I don't. It's not technically part of the routine.
Okay.
Again, that would be based solely on physician preference, but it's not a normal part of the routine.
Okay.
So again, deep breath in and hold it. Right? Breathe and relax. And then keep your arm up. And step a little to your left. Step forward a little bit more. Shift, shift. Okay. So that would be again the RAO, but for a left anterior upper rib injury. Okay. Questions about those ones? All right. Relax and turn around and put your back up against the board. Okay. So let's start with the right because that's how we get used to it. So step a bit back to your right. Bit more. Again, making sure there's no rotation, especially when they start lifting things, right? Make sure that they don't wiggle. Deep breath in and hold it, right? Anybody have to put BBs yet? Okay, so that may be another thing that you're gonna do, right, in this process, is to actually put a mark, right, somewhere where the patient says there's the most pain. Okay. Now,
Would you put the BBs on the patient, tape them like to them, or would you put them on the board?
To the patient.
To the patient. Okay.
All right. Again, 45. There we go. Okay. This would be right the RPO or a right upper posterior injury.
What's your collimation size for all this?
And this is lying to you, but
Okay.
it would be like a 17 by
Okay.
12, 11, 10, depending on how wide your wrist is, right?
Anya, as far as like side of injury and positioning, above and below diaphragm are the same, right? So if this was
Yes.
Okay.
So if these are all uppers, meaning they're above the diaphragm, you center very similar like you would for a chest. So somewhere around that T6, T7. Right? But again, off-centered if you're doing unilateral or bilateral.
Typically, would you do this bilaterally for the routine?
Depends on the protocol.
Depends on the protocol.
So some sites only want the side of entry. So like I said, this is, right, I fell on my back, right, tripped over something, landed on my child's toy, jabbed me just under my scapula, hurt deep in the ribs, right?
Like
Sometimes it is just that side. And then other times they're like, let's get the other side for comparison just in case. So then you would be doing, right, a bilateral AP and then a RPO and an LPO. But that depends. Okay? Alright, so back up against the board again. Shift this way, because now we're going to the left side too far. Better. And sleep. Good. Okay, deep breath in, and that would be it, right? And then again, that LPO. And forward just a cinch. Okay. Right? So that would be the left side. Okay. To do the posterior lower rib injuries, we have to switch gears a little bit. Okay, Michael, you need to lie on the table for me. Stool, give me the stool. On back. Oh, careful, careful. Alright. So, shift a little towards me.
And this is just for the bottom 3 ribs, if you suspect injury there, and that's it, pretty much?
Correct. Where did you go?
I don't know.
Are these always going to be on the table, or can you do this erect as well?
So, according to your textbook, they should always be on the table.
Okay.
Why should they always be on the table?
Something in the background, probably.
It's something to do with the diaphragm. So, gravity helps, right, push the diaphragm further up, so that you have a more uniform density for below the diaphragm.
Right.
So, come on, buddy. So, xiphoid, right? Lower costal margin. So I want to go in between the two, right? And then give myself a little bit of wiggle room on either side. Okay, I am out of table space, so you do have to scoot just a little. Okay, that'll do.
Have you ever had to radiograph the false ribs on the sides?
So this is for kind
Okay.
of your false ribs.
Okay.
Right? Because again, the lower ribs do not, right,
Yeah,
connect.
yeah.
So this is for those ribs.
Yeah.
Okay? Which is why it is a lot smaller, right, than the upper ribs. Okay? So, remember, we're going to do this on expiration. So take a deep breath in, blow it all the way out, right, and then take your picture,
Your light should be a little past the lower costal.
just in case, because I also have plenty of room to the spine, so I'm okay.
So possibly to the lateral skin margins to the spine is probably be a good judge.
Yes. Right? So that should be what you said. All right. Then we need to do an oblique. Did they leave their? Oh, no, they were good and they put their sponge
No
away.
wedge.
Let me go
And
grab it.
wedge, please. All right. Bring that one up. I never had what to do.
No, my phone.
All right, roll towards me a little. Good.
Just to
Yeah.
elongate them.
Probably gonna run into an issue. Make sure that we didn't move all of our other fun stuff.
So how do you find the centering horizontally on this one?
So again, if you're gonna think about, right, going from here to here,
Okay.
but I have more than enough, right, space if I center back there. So I pulled it this way. But anything that will, right, elongate. What's more important is to make sure you have the proper rotation. If you don't have enough rotation, right, not gonna work. Okay? So again, I put an R down here. And then we would do the other side. So, yeah, we will, not that far yet. Gotta do the AP first. Don't get too excited. Okay. Wiggle. All right, so this would be, right, the AP for the left side. Again, these are the lower posterior ribs, so they are not the ones that curve all the way around the side. So just our shorties, right? And again, take a deep breath in, blow it all the way out. Good, okay? And then, now you get to roll to your left as well. Good. And again, deep breath in, blow all the way out. And that would be my yellow pill for the left lower posterior rib.
That's it?
And that's it. Yeah. It seems like a lot, but it's really not that bad.
This is not. You're not moving this at all, is it?
What?
You're not moving this at all, just a patient.
But yeah, because it's already lined up with my bucket.
Cool.
Why would I want to move that? Because if I move one, I have to move the other one.
It was really hard to get down. Like, now it feels normal, but yeah.
Yeah. All right.
Angles.
Okay, questions?
Thank God for no angles, except for the F1.
So sorry again, for just marker placement, you just like put it on the side.
All right, you can sit whenever you are ready, Michael. Thank you for being our patient.